We'll move on to our next speaker. That is Dr. Ruth O'Regan from the University of Rochester. Dr. O'Regan will be presenting an evaluation of the breast cancer index in premenopausal women with early-stage hormone receptor-positive breast cancer in the SOFT trial.
Well, thank you very much, and thank the organisers for inviting me. I'm happy on behalf of my co-authors to present this evaluation of breast cancer index in premenopausal women with early-stage hormone receptor-positive breast cancer enrolled in the SOFT trial. Okay. Right click. Oh. Okay, sorry. Now, I think as this audience is fully aware, the SOFT trial was designed to evaluate the escalation of endocrine therapy, specifically with the addition of ovarian suppression for premenopausal women with early-stage hormone receptor-positive breast cancer. As you recall, in this study, patients were eligible if they'd received chemotherapy and then remained premenopausal after chemotherapy, or if they had not received chemotherapy. You can see here it was about half and half. These patients are randomized to tamoxifen as standard of care for 5 years, tamoxifen plus ovarian suppression for 5 years, or exemestane plus ovarian suppression for 5 years. We saw the 12-year median follow-up from this trial by Dr. Regan last year at this meeting, continuing to show a 3% improvement in freedom from distant recurrence with exemestane plus ovarian suppression versus tamoxifen, and also that exemestane plus ovarian suppression was superior to tamoxifen plus ovarian suppression. So what's the problem? Well, the problem, as we all know, is that ovarian suppression is toxic. Patients can have difficulty with compliance, so it's important that we work out which patients really need this approach. Now, what we know from the SOFT study is that younger women under the age of 35 appear to benefit from ovarian suppression following chemotherapy. Additionally, Meredith Regan came up with a continuous composite risk value that incorporated patient and tumor characteristics, which can be used to decide what patients need ovarian suppression. However, to date, no genomic biomarker has been available to predict the benefit of ovarian suppression in premenopausal patients. As I mentioned, this is critical because of not just the short-term toxicities, but also long-term toxicities, which may not already be fully established. Now, the breast cancer index is a genomic assay that incorporates molecular grade index and the H/I ratio, which is HOXB13 over IL-17BR. BCI has been found to be prognostic in determining individualized risk of late recurrences and also cumulative overall distant recurrence from years 0 to 10 in ER-positive breast cancer. The BCI-N plus further incorporates tumor size and grade for N1 disease. The BCI predictive part is focused on the H/I ratio. This is based exclusively on the ability of the H/I to assess estrogen signaling pathways. And what it does is it reports the likelihood of benefit from extended endocrine therapy as a yes if the BCI H/I is high, or no if the BCI H/I is low. And this has been based on a number of retrospective evaluations of clinical trials. So the hypothesis we set out to test in the SOFT population was, first of all, if BCI and BCI-N plus are prognostic in patients with N0 and N1 disease, respectively, who received endocrine therapy with or without chemotherapy. Secondly, we hypothesized that BCI H/I high status will be predictive of ovarian suppression benefit, whereas BCI H/I low status will not be associated with ovarian suppression benefit. And this hypothesis was based on the data I just showed you from previous BCI data. So the study objectives, the primary objective was to evaluate if BCI H/I predicts benefit for patients treated with exemestane plus ovarian suppression versus tamoxifen. The secondary objectives were to evaluate BCI and BCI-N plus their prognostic ability in premenopausal patients with ER-positive early-stage breast cancer, and secondly, to evaluate if the BCI H/I ratio predicted benefit from tamoxifen plus ovarian suppression versus tamoxifen. The endpoints we used are shown here. For the predictive analysis, we used breast cancer-free interval, which includes invasive, local, regional, and distant recurrence in contralateral breast cancer. For the prognostic analysis, we looked at distant recurrence-free interval. We used Cox regression and log rank tests, stratified our nodal status and prior chemotherapy, adjusted for a number of factors that I'll show you. clinical and outcome data were based on the 2021 database that I just showed you after a median follow-up of 12 years. So here's the case flow. As you remember, there was just over 3,000 patients in the SOFT study. Out of those, there was just over 1,700 who had available biospecimens. There was only 30 that had insufficient RNA quantity, so we ended up with 1,687 patients in the BCI translational cohort. Within this cohort, 573 patients received tamoxifen, 551 received tamoxifen plus ovarian suppression, 563 received exemestane plus ovarian suppression. And what we noted was when we compared the BCI analysis cohort with the soft intent to treat cohort, really the tumor and patient characteristics were mirrored very nicely, whether you looked at receipt of chemotherapy, nodal status, age, tumor size, tumor grade. Also for HER2 status, and just to remind you that both within the intent to treat population and in the BCI analysis cohort, about 12% of patients had HER2 positive cancers. So let's first look at the prognostic ability. So here we're looking at BCI, including molecular grade index and the H/I. Looking first at patients with node-negative disease, 60% of them had BCI low cancers, 22% intermediate, and 70% had a high BCI cancers. And what you can see on the left-hand part of the slide is that it was highly prognostic. So you can see here in patients with node-negative disease, as the BCI increased, so did the rate of distant recurrence, and that was statistically significant. On the lower right here, we're just looking at outcome based on whether patients had high, intermediate, or low BCI, and you can see that it was prognostic in terms of outcome. Looking at patients with N1 disease, 22% have BCIN plus low, and 78% had high. And again, you can see here on the right-hand part of this slide that the BCIN plus in N1 patients was again prognostic, so as the score went up, the recurrence rate went up. And on the bottom part here, you can see that patients who had a low BCIN plus did better than those who had a high. I will say that the BCIN plus risk groups were very highly correlated with tumor grade, in that the low BCIN plus group, almost all of them had grade 1 cancers. The high group, however, you can see that most of them had grade 2 or 3 cancers. So now let's look at the predictive results shown here. So this is looking at the H/I ratio. So overall, unselected in the BCI translational cohort, you can see here that the benefit for exemestane plus ovarian suppression or tamoxifen plus ovarian suppression compared to tamoxifen mirrors what we saw in the overall SOFT study. Within this group, about 60% of cancers were BCI H/I low and 42% were BCI H/I high. Contrary to our hypothesis, what we found was in the BCI H/I group, there was all the curves were superimposable, and this was not predictive for benefit from ovarian suppression. In contrast, in the BCI H/I low group, you can see here that looking at exemestane plus ovarian suppression versus tamoxifen, the difference was almost 12%, and tamoxifen plus ovarian suppression compared to tamoxifen was 7%. And the treatment by biomarker interaction was significant for exemestane plus ovarian suppression versus tamoxifen, but less so for tamoxifen plus ovarian suppression versus tamoxifen. So here we're looking at the hormone receptor positive HER2 negative group. So this is taking at the 12% of patients who had HER2 positive cancers. Again, you can see in the high group, this was not predictive for any of the treatment arms. On the low group, again, you can see a 13% benefit for exemestane plus ovarian suppression and 7% for tamoxifen plus ovarian suppression compared to tamoxifen. Looking at chemo versus not, we know this is very important in the SOFT study. On the top part, we have the patients who got chemotherapy, and again, the same results. No predictive ability in patients with high H/I scores, but in a low score, you can see there's about a 16% benefit for exemestane plus ovarian suppression, 11% for tamoxifen plus ovarian suppression compared to tamoxifen. In the lower part of the slide, looking at patients who did not get chemotherapy, they did better as a whole, but again, really no predictive ability in the high group. In the low group, you can see 9% for exemestane plus ovarian suppression and just over 5% for tamoxifen plus ovarian suppression compared to tamoxifen. Looking at nodal status, on the top are patients with node-negative disease. Again, no difference in the high group. In the low group, the difference now is 4.5% for exemestane plus ovarian suppression, 10% for tamoxifen plus ovarian suppression compared to tamoxifen. In the node-positive group, this was fewer patients, but again, the same kind of trend here. No difference in the high group. In the low group, 6% for exemestane plus ovarian suppression and 3% for tamoxifen plus ovarian suppression. And lastly, just looking at age, looking at younger patients under the age of 40 on the top part of this slide, what you can see again is in the high H/I group, no difference between the arms, but in the low group, 11% for exemestane plus ovarian suppression, 8% for tamoxifen plus ovarian suppression compared to tamoxifen. And in patients over the age of 40, again, the same results, no difference in the high group, about 12% for exemestane plus ovarian suppression, 6% for tamoxifen plus ovarian suppression compared to tamoxifen. So in summary, the BCI translational cohort, which was just over half of the patients enrolled in the SOFT study, was representative of the parent trial. The BCI risk scores were prognostic in premenopausal women with hormone receptor positive tumours receiving adjuvant endocrine therapy plus minus chemotherapy. In that, higher BCI risk scores were associated with a worse outcome. The BCI H/I was predictive of ovarian suppression benefit. However, contrary to our study hypothesis, the BCI H/I low group consistently derived clinically meaningful benefit, while the BCI H/I high group did not. We're not sure what these results mean, but it does point to potential differences in tumour biology underlying the ovarian suppression response. So in summary, this is the first genomic assay to demonstrate benefit from ovarian suppression, supporting additional clinical utility and validation of BCI in premenopausal women. So I'd like to thank all the patients, physicians, nurses, trial coordinators, pathologists who participated in SOFT and provided tumour blocks facilitating this. Also support for central pathology included Susan G. Coleman for the cure and also BCRF. The study was approved by the IBCSG Translational Research Working Group and was funded by Biotheranostics. And SOFT is sponsored and coordinated by the IBCSG in collaboration with these other networks. Thank you for your attention.
Thank you for an excellent presentation. As folks approach the microphones, I'm going to ask a question about whether or not you've taken into account in any planned or current analyses more basic. You said they were highly correlated, but grade, degree of ER positivity, or PR positivity in terms of the prognostic and predictive?
No, we have not looked at that. I think that we are planning to do that, but we have not looked at it yet, but it's a great question.
Thank you. Microphone 3.
Hi, my name is Christian Koberg from Germany. Thank you for that presentation. We were really looking forward to data that allowed us to discriminate patients from the SOFT and text trial really by risk, so we really know whom to give OFS and whom not. What puzzles me about the presentation, and maybe that's a very simple question from a clinician, is and on one slide you had one table demonstrating that grade and BCI were very I didn't see a correlation, but there was an overlapping, and especially node-positive patients. Did you control for grading in your results, or with other words, do we see grading in that result? Then do we need BCI, or can we simply take grade?
No, grade was controlled for, and I will point out that was BCIN plus. That wasn't in the overall BCI, and also wasn't the H/I ratio. So that was a fairly small number of patients in the overall analysis. And previous data have shown, that BCI it has more than just grade, if that makes sense. But great question.
Okay, microphone 4.
Christoph Thompson from Germany. So thank you very much for this presentation. I think BCI is really a highly performing prognostic factor. However, I do have two questions. The one question is, how did you select the cutoff points for BCI? And the second question is, using aromatase inhibitors, we have seen in the overall analysis an advantage for AI plus OFS. However, in terms of overall survival, there was no advantage. And I would be interested, how is it now with your selection? Do you see an overall survival advantage now?
So I'll answer the first part first. And we haven't looked at overall survival at this point, but obviously that's something that we probably will look at. As far as the BCI cutoffs, that was what was done in the prior analysis, so that's essentially what we use as well, the same cutoffs.
One more question at microphone 3.
Oprugo at UCSF. Very nice work, Ruth. I'm really glad that you were able to get this project done and presented. Question is difficult. So we saw at ESMO the IDEAL trial looked at extended AI therapy, and we thought about BCI as a way to try and help us think about who might benefit from longer duration endocrine therapy. But I'm finding it hard to put all this together. In IDEAL, it looked like those with the highest clinical risk benefited the most from extending endocrine therapy, which other studies have shown. We've seen that ovarian function suppression seemed to benefit patients with higher clinical risk. This looks like we're seeing something a little bit different, where BCI doesn't correlate well with the clinical risk.
So are you referring to BCI or the H over I?
Well, the H over I.
Right, so the H over I, so yeah, that was not what we were expecting, right? But I think it is a different scenario. So, I think maybe what you're seeing with the high H over I in the extended therapy is that they're more kind of endocrine sensitive cancers versus, and don't ask me why this would be, but perhaps with the low H over I, they're more endocrine resistant. I can't explain why ovarian suppression would be more effective in that group, but I think the way I just look at this is that I think it's a different scenario because you're looking at patients kind of up front versus after they've had 5 years of endocrine therapy. But it obviously wasn't what we were expecting, but hopefully we'll work out why it was.
Thanks.
Thank you very much, Dr. Ream. We're going to move on to our next presenter.